So, welcome to the show. I'm joined by my guest, Dr. Daniel Lane. Welcome to the show.
Hi, thanks for having me. Appreciate it.
Yeah. So, you practice functional neurology out in Silver Springs, Maryland. Is that correct?
Yeah.
Yep. And we are looking to talk about dysautonomia today, and that is a huge topic in, I would say, our field. So, I'm really excited for this conversation.
Yeah, thank you for the opportunity. It's we could go on for days, but we'll try to hit it a little bit and keep it kind of light.
Right. So I'm always curious when I have a guest on. I like to ask how they got into their particular field and what drives their passion for working with these particular conditions.
In general, I got into chiropractic, which is a long story after basically deciding not to be a surgeon, which I had worked towards my whole life, and knew I worked in a hospital and was a nursing assistant and worked on every floor. But just it seemed like quality of life wasn't there. And so, and then eventually I went into chiropractic and, it was fantastic, but I was always a little bit dismayed with the profession. It seemed as though nobody could agree on that very thing, which it was that defined the profession, which was what the subluxation complex was. And the more education that I got towards that end, the more it reinforced that. And I almost ended up going back towards the medical fields, and then talked to my primary physician at home, who was like a mentor to me. And basically, he said, listen, that's the same thing everywhere. And he says, we never agree on anything in healthcare. So I realized I hurt people for a while and then, fix something else. It's like, oh my God. Okay, well, so he says, go back, try it again. So I did. And thankfully within that, I was exposed to Dr. Adam Klotzik and the functional neurology program. And then eventually Dr. Carrick. And it was incredible. And it was something that very early on in the career, but I'm kind of an obsessive compulsive type person with my own brain lesions. And I knew I wanted to be the best doctor I could, as well as the best neurologist. And I couldn't really be an expert in both simultaneously. It was too much. So I waited till I had graduated and then took the courses from there. And it was nice because it gave me a fervor, it was something that I waited a long time to be able to do. And the reason I did it is because it transcended everything in our profession regarding modalities and different theories of application of how chiropractic works. What is the subluxation complex? And it basically unified everything, and really gave me a directive. It allowed me to love my profession, to love treating people, and thankfully I was exposed to it, and to Dr. Carrick, the genius that he is.
Yeah.
So, yeah.
Yeah, and we have a lot of our guests attribute their love for neurology and their education to Dr. Carrick. So another great shout out to him and all he's done. But yeah. So let's get right into the topic then. So obviously talked a little bit about who you are and why you got into it. But dysautonomia is such a big thing that I think is affecting a lot of people who may or may not know that that's what they're dealing with. Can you kind of just give us a rundown of maybe what dysautonomia actually is?
Yeah, absolutely. Be my pleasure. So, again, it's a complicated topic, and I find that the term dysautonomia, and I'm certainly no expert in this field, or probably any field for that matter, but the term is one of generalization. To mean dys means bad. If we break it down, autonomia pertaining to the autonomics. So you have bad regulation of autonomic function. And so, when I explain this to patients, oftentimes we'll first see this, and many times they don't even know that they're having this necessarily, but they may have a sequelae of symptoms that just don't make sense to them. And oftentimes it doesn't make sense to a lot of other providers as well. If you understand nervous system function as much as we can, it doesn't mean that we know everything about it for sure. But every day we learn, and learning more and more and more. But the functionality of the nervous system, and if you have any aberrancies therein, a lot of times will lead to a certain subset of symptoms, some more common than others. And that's the term that we use to say, okay, well, dysautonomia. Within our, what we typically do is we're checking autonomic function of blood pressures, which is done bilaterally, checking for postural responses to tilt or sustained tone of musculature, such as grip strength, and checking the cardiac function associated with that. And so if you have any aberrancies in that, then you can have this very generalized term called dysautonomia. And so when I first had the pleasure of treating some of my patients with this, many times they had for years been undiagnosed and really did suffered quite a bit. And thankfully, we were able to help them manage it. And some of them, many of them, I haven't been able to help, but some of the more severe ones I've actually sent to Dr. Carrick, and he's been able to help tremendously. And we've been able to break new ground with a lot of these cases that suffer with a condition for which, if you check the literature, there's no known cure. Okay, but I am always careful to tell patients I would never tell them that we're going to cure them, all right? Because when you read that, there is no known cure. However, we can't help everybody, and certainly we have our failures, but a good overwhelming percentage do very well, and many of which I've never seen again once they're stable. And so what does that mean exactly? I don't know. I've never followed up, but they haven't come back.
So, sounds like you did your job. Job well done. Great. Yeah.
Love our patients, but we love not seeing them.
Exactly. Yeah. It's an interesting paradigm, but
right. Yeah. But I find that the and I'm not exactly sure if we can quantify, a primary versus secondary. In other words, like an actual ablative versus an acquired. But I tend to use the term dysautonomia fairly loosely. All right. Now there's certain conditions that we're going to want to rule out, and patients would want to rule out, that are somewhat pathological in nature or have a disease paradigm associated with them. So anything that might affect your adrenal glands, you want to watch for pheochromocytomas, adrenal medullary hyperplasia, various things like this. If you have a condition such as that going on, that's going to make treatment much, much more challenging. But thankfully, the overwhelming majority of people have what I coin as, and again, I'm not sure that I'm correct in coining it, but an acquired dysautonomia. And one of the most common reasons for acquired regulation of your autonomic nervous system function is because of concussion. So typically is that, for those who don't know, the autonomic nervous system controls the things that we often don't think about, such as blood pressure, heart rate, pupillary constriction, digestion, urination, gastrointestinal function, etc. And so with many people, when they suffer a head injury, whether that be mild over time or a concussive event or a traumatic brain injury, what have you, or even a pathological consideration affecting the brain, many times the brainstem is affected. And that brainstem function is pivotal in governing and regulating and managing your autonomic nervous system function. So there are ways to measure that. And a lot of times people, when they have this condition, they don't know what to do or where to go. This constellation of symptoms is so vague that, normally when you do this long enough, you can predict the patient's symptomatology, just based on, many times just in a conversation with them. And and it's very humbling to and moving to hear them cry when finally someone understands their condition and reaffirms that they're not, losing their minds.
Absolutely, absolutely. No, that's a good point. And then,
Yeah.
And so you had mentioned that this brainstem is affected typically in dysautonomia, especially acquired dysautonomias after concussion. And obviously the autonomic nervous system is going to control a lot of our vital functions for everyday life, correct? So if we know what it does, what are some examples of way that it might malfunction, so to speak? Some of those vital functions that these patients might be having issues with.
Right. Great question. Usually the symptom subset is going to be one that either reflects an aberrancy in function in either the sympathetic nervous system but normally the parasympathetic nervous system, at least in my experience. And so to explain that to people, your autonomic nervous system has this balance between these two systems of sympathetic fight or flight nervous system versus the rest and digest nervous system. And so, when we have that sympathetic rush, we've heard of mothers, fighting off bears and tearing doors off cars to save their kids, where you're super fast. And they basically, this is a natural, response with any organism on Earth that's been around for years that keeps you alive and responsible and responsive to the environment. Okay. And that increases blood pressure, increases vasoconstriction oftentimes, decreases gut function. And so it's a normal, essential part of life, and it's used every second of the day. And its counterpart is the rest and digest parasympathetic system. And this is, after you eat, you get sleepy and tired, or when we're in a restful state. And these two systems are constantly at play in this beautiful, harmonious dance. Okay, so it's never it's never a total loss or dysfunction in one or the other, because you would cease to live.
Exactly.
But what tends to happen is that upper brainstem really loves to regulate the activity of the spinal cord and then the sympathetic nervous system, whereas the lower brainstem is just the opposite. And so oftentimes what we can see is if we damage either with hard damage, like in an ablative lesion, or a non-physiological or non-ablative lesion, as we call them, or a functional lesion, you can change the structure or the function rather of the brainstem, and thus perpetuate these symptoms. And so the most common ones that we see tend to be patients who are suffering with episodes of blurred vision that you blink and then it goes away. Motion sensitivity, light sensitivity, something we call photophobia, sound sensitivity, which is phonophobia or hyperacusis. You'll see aberrancies in gut function oftentimes, depending on what stage and how long they've had it for. Typically see constipation or decreased gastrointestinal function, and then frequent urination because they're never truly emptying their bladder. Sometimes they can have a higher and urinary tract. And so a lot of times also you're going to see, due to other mechanisms, insomnia or anxiety or emotionality going on with it. There's kind of like a wind-up mechanism of that upper, when you've had too much coffee, think of it like that.
Mm-hmm.
Okay.
Exactly.
And so, and it's difficult to calm down. And the tricky thing is that upper brainstem also regulates the majority of eye movements in the vertical plane, up and down. So if there's problems with that, unfortunately, when we move and we walk, we bounce. And we have these reflexes in our head that keep our eyes locked. But you hopefully those reflexes are working. But if because you have that can help save you. But if your eye movements are having a hard time in the up, you're going to have a hard time even walking, which is then has a potential to affect heart rate, the cardiac rate, the blood pressures, and life can be horrible for these people because they can't even move.
Yeah.
And so, now the conventional the conventional method of treating these patients is such that medicine, medicine's wonderful. Thank God for it, and I would never want to disparage things. I just truly feel like we want to try and figure out causation. And not that they don't, but as I tell my patients, medicine's wonderful when you're broken. And that's just an amazing thing that they have, an intervention and paradigm that they can assist with. But if you're bent, many times they don't often know what to do with you, particularly in the realm of neurology. You're negative on all their tests. And, they're like, well, we know you have these symptoms, so we don't know what to do about it. So, they have big hearts. We'll try to use this medications and, help the patient, and hopefully it goes away.
Yeah.
Or they're waiting till it does break. And then you can quantify it and show it on the imaging and the testing and the blood work and everything else. And then they know what to do with you, which is usually just, more medical management and sometimes surgeries. But like I said, thank God that paradigm is there. We need that. But as I like to say to patients, we want to see you when you're bent, not broken. Okay. And if you're bent long enough, it's breaking. Okay. So your body will give. Yeah. Thank you. So your body gives you these signs. And if you're trained in how to look for these signs, then that which seems to make no sense makes perfect sense. And it doesn't mean that we're smarter or better or anything like that. It's just a total different paradigm of education.
Yeah.
I give, lectures to neurosurgeons and other neurologists and medical professionals, and frequently they're like, "Oh my gosh, this is amazing." And I said, "Well, yeah, it is. It's thankfully it's not due to me, that's for sure, but what they do is amazing, And so it's just its own thing, and by combining in a good healthcare team all the different professionals, I think that the patient has the best shot at getting better.
Absolutely. And that's a good segue where you were talking about how you would assess the autonomic nervous system. So what kind of sets you apart, and what's your niche role as far as assessing and evaluating and examining these patients with dysautonomia and autonomic dysfunction?
Right. Well, many ways actually. So we're always checking autonomic function when patients come in, because that's just a part of a good doctor should still be doing exams, which you don't see pretty much ever anymore. Yeah. All right, but part of our physical exam is taking vitals, looking at respiration rate, looking at pupillary dilatation, indoor constriction, doing the cranial nerve functions, checking blood pressure, heart rate variability, pulse. And so usually you can find it just on that, which is just the basics. Okay. Yeah. But many times, admittedly, in our clinic, I like to joke with people. We're functional, AKA chiropractic neurologists. We're not first on their list. They've probably been to 20 people, and have finally found their way to our place. And that's fine. That's, because we need to get the word out more, and that's okay. But as a result, they've usually had all the testing. Okay. But what we're typically going to see with dysautonomia patients is that there's going to be significant abnormalities to blood pressure function and pulse as a result of either tilt table testing, which we'll do in our clinic. They've usually had via cardiologist or a primary who's astute, and referred them towards that end. And then other forms, like just this last weekend, Dr. Carrick was explaining about a hand dynamometer test. And so we can use that to assess, aberrancies in postural reflexes with such a thing as orthostatic hypotonia, or you can have baroreceptor dysregulation of these different parts in your body that go in the heart and the aortic arch and the carotid sinus in your neck. And you want to make sure that these, what we call graviceptive receptors, that means they respond to gravity, that they're working right. And oftentimes with these patients, they are not. And so what we have to do is test them first and find out, okay, well, what is happening with this system, and are these receptors working properly? And then what's happening with the overall system of the brain and its function and stability and maintaining this autonomic nervous system. Unfortunately, with which familiar with the there's a program in Cleveland, I believe in Mayo for sure, and I believe in Cleveland, that has the functional functional institutes that they use towards treatment of these conditions. And what they basically do is treat patients, very intensely for a week, and then they give them lifestyle management tools, which we give everybody, and that's basically utilize, compression socks to help return blood to the heart, to cell volumize by hydrating well and eating salt if you can, and to exercise, because it's the contraction of muscles of the lower extremity that help bring the blood back to the heart. Mm-hmm. So, that's one of the main things that these people have a hard time with, is by the time that the blood hits the feet, the return blood pressure is very low. Right. So these are all aspects that everybody should be telling their patient. But the hard part for them is, you can't just activate the lower extremities because of the metabolic demand on the muscles of the system, which is frail. Yeah. So, for instance, give them single leg presses done supine, and that was a wonderful thing that a colleague, Dr. Traster, had pointed out, and it's just made a huge difference for us clinically. So being careful to attend to the metabolic capacities of these patients and not exceed it, and slowly build them up, first laying down, one leg at a time, then two legs, then sitting, then standing. But more importantly, the reason I think that most of medicine has such a hard time in dealing with this is because the drugs cannot specify the area of dysfunction in that nervous system. Right. With a careful exam, diagnostics, and an analysis, we can then determine very specifically what areas of the brain may be not functioning as well as others that may contribute to this. Mm-hmm. And so just in general, we have that upper brainstem hitting that sympathetic nervous system. And so within there, you might have findings that show that area is got too high of a function or too low. Mm-hmm. Then we have the lower brainstem function underneath that, which, again, is that too high or too low? Or is it higher, what we call supracortical, cortical areas, and their descending modulation, their how they regulate these areas in the lower brainstem. And so by putting all of this together, we can then paint a wonderful picture of specificity that's targeted towards that individual patient and none other, and then do therapies that activate those specific areas. Right. In the medical game, they have to use a drug, mm-hmm. Which can be good sometimes. However, it can't be specific, mm-hmm. and so the drug affects everything. Yeah. But patients have a hard time between, waxing and waning, and the next thing you know, they're on 1, 2, 3, 4 different drugs, then other drugs for the side effects, and a nightmare to the autonomic nervous system. Absolutely. And you, so once you're able to kind of figure out, whether one part of the brain is hyperactive or hypoactive, or which area is dysfunctioning, then you're able to create a treatment plan specifically designed for that patient. Correct. So could you talk on maybe some of the treatment strategies that are non-pharmaceutical that you're able to utilize in your office to help these people? Yes, absolutely. So in general, when we say as a chiropractic neurologist that we're going to be doing neurological therapeutic intervention, or in a context of clinical neuroscience, essentially we're using different forms of therapy that have been around forever. It's not a new concept. It's just the brilliance of Dr. Carrick and how we put it all together. And there's a whole lot of what we call ocular motor therapy. And so that's therapy involving the visual system and not necessarily how I see, although that's sometimes a part of it, but more importantly, how eyes are moving. And there's 7 or so different eye movements that the brain does, and then there's different parts of the brain responsible for those eye movements, for generating them, for integrating them, for making them happen. And so we can use, in the literature supports that using the visual system, or specifically ocular motor system, can be a wonderful window into the brain, and it's not only pathology but function. And so you'll see whether we will use a combination of these various ocular mechanisms or eye movement mechanisms to target various parts of the brain. Vestibular rehab is also a wonderful thing that we employ, or therapy that we employ. A lot of people do vestibular rehab out there. The main difference is that we are neurologists. We are trained and certified and fellowship, have fellowship designation in these areas and in these fields. So where most of the time physical therapists may be doing vestibular rehabilitation on more of a peripheral-based model, okay, ours is more of a central-based model. It's the projections of that vestibular system to the main brain, to the main cortex, and how we can then use that very, very, very powerful system to make effects in other areas. And so you will see typically a combination of vestibular, ocular motor, proprioceptive, which is, the somatosensory type system of muscles, ligaments, joints. And we will use that in a very specific context to allow the intervention to potentially assist the patient. Yeah. What I love most about it all is that it's quantifiable, and we can use diagnostic measures that we have, machines and various testing apparatus and equipment, to quantify function, okay, besides the bedside exam, which is really all you really need, but I mean, it's nice to be able to quantify these things. And then we can employ a treatment intervention strategy and then retest. And so, the thing that I tell my patients all the time is, once we've done our entire intake exam, read a thorough history, read all of the documents, run all of our tests, done a physical, another diagnostic test, I can then generate what I call a probability index, and what is the probability that I can help in this case. Nothing's guaranteed, but if it's something that I'm well trained in, I feel pretty good about it. Others, and patients are really receptive to this, and they, I'll just tell them, I said, listen, I don't know what I'm looking at. This is strange. I see some of these things, and I know there's a good chance I may know where they're coming from, and perhaps we can address that and see if there's an improvement. Would you even like to try? So you see the full range of spectrum based on the disorders that present to our clinic. But with autonomia patients, we tend to do fairly well. And I'll tell them, there's a good, 50, 60, 70% chance we'll help, and a good 20, 30% chance that we can't. Yeah. But it won't take a year to figure that out. We should see in a few weeks. And doesn't mean they're fixed, but we've always got to have something to bite our teeth into to say, hey, listen, look, this is going the right way. And usually the objective and the subjective match up.
Absolutely. So, and that's, at the end of the day, one of the most important things is, you want to make sure that you're getting these objective findings better, but at the end of the day, if you're not improving subjective symptoms, then what are you doing?
Right.
But so that's great that you're able to match the two and show that they correlate, and that because you are fixing these objective findings, these brain markers, that subjective symptoms are getting better. So
yes, it's wonderful, and patients appreciate it, and they understand. Then it just allows you, I find it's very liberating to the clinic, because they know that this is not a cash grab, that you're doing everything for the sake and benefit of that patient. We're not selling programs. We're not, we're seeing them fairly regularly, and quantifying that change. And at the same time, if there's a plateau, we may try a couple other things, and if nothing's changed, that may be it. And, they love the fact that, well, it didn't take 50 visits at a plateau to figure that out.
Right, right. I'm sure they appreciate that.
Right.
So Dr. Lane, we're almost out of time, so I wanted to just give you this moment to give us any final thoughts, and then let us know a little bit about how to find you and your clinic and any other projects you might be working on. Yes.
Final thoughts. Thought number one, close the door when you have 4 young kids. I apologize for the background, and if you can hear that. Okay, thank you. That's excellent. We're easy to find. We're at for now at the Holy Cross Hospital in Silver Spring, Maryland. Okay, in the physician specialty building. You can look us up online at Mid-Atlantic Brain and neurological rehabilitation. So that's a mouthful, but it's MABNR, mabner.com. Okay. Yeah, we'd love to see you. Our website is very robust and explains quite a bit. And I think, and this is what I take pride in more than anything, is the team of other doctors which we've assembled and other healthcare providers that we've assembled, not only within our community, and being with clinics such as yours, and Dr. Michaelopoulos and Dr. Traster, and I mean the list goes on and on and on, and Plasticity and Dr. Carrick and everybody else, but also the providers in the local areas. And so we've worked hard to establish wonderful relationships with physicians and other people that are open and that love to work with other people towards getting these better, because so many times these cases with these patients, you're going to need a multidisciplinary team approach. And as I say, to the patients, you got to find a whole lot of doctors that are willing to play in the sandbox together. And thankfully, we've got wonderful connections towards that.
Yeah, absolutely. I agree. Well, thank you very much for your insight today on this complex topic and taking the time out of your day to have this conversation with us. I think a lot of people listening who are suffering with dysautonomia they're gonna realize a lot of answers and a lot of things that they may not have known before. So thank you very much.
Thank you so much. I appreciate the opportunity, and to all those listening who have it and maybe had Ehlers-Danlos syndrome. There's so much more that we didn't get into, but have hope. All right.
Yeah.
There's always hope.
Yeah.
Okay.
And we could probably talk about this for days, but yeah,
sure.
Maybe we'll have a second one, and we'll get Dr. Bryce on here with us.
Part 2, I'm game.
Part
All
2,
right.
sounds good. Well, Dr. Lane, it's been a pleasure. So I'll let you enjoy your evening.
Thank you so much, Dr. Joe. I appreciate it. You take care.
Yeah. And then this has been your host, Dr. Kappas. Be well.